Have you ever taken care of a patient that's had a muscle spasm that's continued for days? So if she doesn't correct her electrolytes in a certain period of time, it could be. But that was a distractor. Doesn't matter at the time. She's got a back problem. What's the most likely reason? Okay, so here we go. Talking about opioids. This comes directly out of Stoltine with some pictures out of Evers. We're going to talk a lot about morphine because it's the prototypical opioid. We'll talk a little about fentanyl, sufentanil, talk a little bit about Stadol, Narcan, the drugs that you most likely will see. Now, we spent a lot of time on the descending pain pathway talking about endogenous opioids. Well, they've got to come from somewhere, and these are the substances that they come from. If you have the word pro in front of a substance, what do you know that happens to that substance? It gets changed by metabolic processes in the body, and it turns into a substance that the body can use. It's a prodrug, if you will. And so you can get opioid substances from POMC, the pre-pro opiomelanocortin. You can get enkephalin from pre-pro enkephalin, and dynorphin from pre-pro dynorphin. Now the thing to focus in on here is, in regards to the POMC molecule, when it gets cleaved, it makes this thing called beta endorphin. And that beta endorphin will stimulate mu receptors. It'll stimulate delta receptors. And that will give you some analgesia. As well, the proenkephalin and the prodynorphin, what do you think that they turn into? Enkephalin and then dynorphin. That's right. Now, what will they act on, right? They will act on the opioid receptor. Now, you don't have to memorize any of the sequence. Just know that it's a 7-membrane receptor. 1, 2, 3, 4, 5, 6, 7. It's got an amino end and a carboxyl end. The amino end is extracellular. The carboxyl end is intracellular. And that's where binding takes place both on the outside and the inside. What's going to bind to it on the inside? G proteins. The opioid receptors that you need to be concerned with are the mu, the delta, and the kappa. If you see the terminology MOP, that's mu opioid receptor. If you see DOP, that's delta opioid receptor. And if you see KOP, that is kappa opioid receptor. Who can see the spelling mistake on Evers' chart? Preferred? This is preferred spelled wrong? Aha! So that editor missed it. Now these are the preferred ligands. Does that mean that they're the only ligands? And does that mean that that ligand will only bind to that receptor? It prefers that receptor. But if that receptor is saturated, will those substances bind to other receptors? Yes. Because an opioid receptor is an opioid receptor. Now, before we get to the mechanism of the opioid receptor, I want you to focus in on the mu receptors, the kappa receptors, and the delta receptors. This is what they do. It's not how they do it yet, but this is what they do. So you have mu1. Mu1 is important to you because it will modulate analgesia, and mu2 will also modulate analgesia. You will get spinal analgesia from both mu1 and mu2. You will get more supraspinal analgesia from mu1. mu2 will also give supraspinal, but given the choice, mu1 has a higher degree of supraspinal analgesia. What does that mean, Mark? above the supra, above, right? So the brain. And what do you know starts in the brain? Descending pathways, right? Gate control mechanisms up there. You also inhibit the sensory input into the somatosensory cortex. So all of that is going on in the brain. And so there's a high preponderance of mu1 receptors up there. Now, the reason people like to get high is mu1. That is what gives you the rush, the euphoria. But it is not what causes the physical dependence. That receptor is mu2. Don't know why. It just appears that mu2 modulates physical dependence. I don't care that you know that, but somebody's going to ask, well, why does it say low abuse potential for mu1? Got to ask Stolting on that one. See what studies he cited. I do know, though, you give an opioid, and what happens to heart rate? It goes down. Why do you think? What do you think the mechanisms are for heart rate decrease? Just intuitively.
Block sympathetic outflow.
You inhibit sympathetic outflow, right? Now this also tells you that there has to be mu1 on the heart as well as mu2. So if I activate mu1, which is a GI protein, in the heart, can you understand why you see bradycardia? You are stimulating an inhibitory protein in the heart. You are inhibiting ion flux, or you are increasing hyperpolarization, as well as decreasing sympathetic outflow. So you could see a bradycardia, and especially with fentanyl, and I will tell you sufenta and remifentanil, very good at decreasing heart rate.
Pre-synaptic?
It can be post-synaptic, but that's not the important part yet, because opioids are going to work both pre and post-synaptic.
You used to serve mu receptor 1 or 2 in the heart?
The higher concentration will be mu1 in the heart. There, again, this is when you see these charts and you see something that's highlighted, that just means the preponderance is related to that receptor. It doesn't mean that there's not other receptors that help with this, but this is what have been shown most likely to occur when you stimulate these receptors. The meiosis. Why do you think that happens? The sympathetic outflow is decreased. And you're going to learn about this thing called the Edinger-Westphal nucleus. It will actually increase parasympathetic outflow to the ciliary muscle of the eye and through a GQ protein receptor activated by acetylcholine, the eye will tighten up. Right? That's most likely what kind of a receptor? Muscarinic 3, right? GQ. That meiosis is an effect that really doesn't go away over time with someone with abuse. So when it comes to tolerance, that as well as constipation, they don't really go away. You don't really become tolerant to those two effects. Why do people love Demerol? Because of the kappa receptor. Right? It makes them stupid. Makes them high. It's not real good for pain control, but it does alter their mentation. And so when you give it and you see that the patient is loopy, you can attribute that to the kappa receptor. Some people respond well to it, others not so well. And that's where they might get a little dysphoric. I've highlighted some agonists here in green, and I've highlighted some antagonists, but we'll get more focused on those as the lecture progresses. I've also helped you by checking certain items in this particular box. You'll notice that I have slides that I spent the weekend on trying to assist you and focusing you guys, and I will repost these this afternoon. I also hope you appreciated my artwork. Yes?
My question, like you said, does that have anything to do with the special procedures?
The question would be, does it lower the threshold? What do you mean? I'm maybe not understanding. You're saying it's making it easier for a seizure? So that's a metabolite. Normoparity. We'll get to that. All right, so again, please understand that the endogenous opioids have a preference to the receptor that they bind. You're probably going to see that again. Please understand that mu receptors are going to cause a bradycardia. Understand that mu2 receptors are going to cause a depression of ventilation. So mu1, mu2, kappa, and delta. Those are your receptors that you're responsible for. And then the check marks. As well, you might be asked to state the preference of certain drugs for receptors. Because remember I said that drugs will not just bind to one receptor. So this is a chart that focuses you on a limited amount of drugs, because this chart was 24 drugs long, and I cut it down to 7. You've got 4 of the opioids that you probably use most often. You've got 2 of the agonist-antagonists that you may have used, and your reversal agent for narcotics, opioids, the Narcan. When you see a plus, 1 plus, it has a small affinity for the receptor. 3 pluses, it has a great affinity for the receptor. If you see a P, it's a partial agonist. But that also means it's a partial antagonist. If you see a red minus sign here, that means it is a pure antagonist. And the 1, the 2 versus the 3 minus signs show you an affinity for the receptor. Are there any questions on how to read this? Why might you use something like butorphanol versus fentanyl intuitively? Say you are the only nurse on the floor. You had 12 patients.
Longer duration.
Okay, duration. What receptor is responsible for respiratory depression? Mu. Does this fully activate the mu receptor? So do you think that will depress respirations as much as fentanyl if you've got 12 patients and you're trying to get them some pain relief? All right? I'm not saying that's what happens, but it's an academic question I could ask you. So there's this respiratory ceiling effect that you get. But with that, there's also a ceiling effect on the amount of pain relief you can get with a partial agonist. Butorphanol, also known as Stadol, is used a lot on the OB deck because it maintains ventilation, but it doesn't do a very good job at pain relief. So anybody who's been up there and used this, they'll have a woman who's screaming during contractions and then falls right to sleep between them. Wakes up screaming during contractions and then falls right to sleep in between them. That's what Stadol does for you. And it has to do with that partial agonist activity. But how many of you have used Sufenta or fentanyl? It works pretty well, doesn't it? You give it, it works right away. It's very lipophilic. It has a high specificity for mu receptors, and that is what takes away your pain. But it also takes away what, Matthew? Your respiratory drive. So where do you have opioid receptors? Are they in the periphery? Yes. Are they in the spinal cord?
Yes.
Are they in the brain?
Yes.
They're everywhere. Opioid receptors are everywhere. Spinal, supraspinal, and peripheral. That's why some people will advocate using opioids in your peripheral nerve block. Not only can you hit the sodium channels, but you could block the peripheral or inhibit, or activate the peripheral opioid receptors. I can't stress enough the bradycardia and the hypoventilation that occur with mu1 activation. I can't stress enough the hypoventilation that occurs with mu2 activation. Now what happens? You guys have been beaten down by G proteins to death. So I'm going to let you read this on your own. But I do want to introduce you to a couple pictures you may or may not have seen. And if you've seen them, try to help explain them to you. I've got the two red boxes here. And these are what happens when you stimulate a GI receptor. There's two things that happen. If you remember, your G protein has an alpha, a beta, and a gamma subunit. And usually, it's tradition or it's iconical to tell you what the alpha subunit does with the GTP bound to it. But don't forget that the beta and gamma subunit will also go on, dissociate, and have an effect. All right? You all know that the GI, or the alpha subunit of GI, is going to inhibit AC. Said that forever and ever and ever. You get that. But it's actually the beta and gamma subunits that will hyperpolarize and decrease calcium influx. Now, if you've known that, we just reviewed it. If not, try to focus on that. Now, when you activate the GI, the G alpha sub I subunit, and it dissociates and it's bound to GTP, not only will it inhibit AC and inhibit the formation of cyclic AMP, but it does other things. Right? It'll phosphorylate ion channels. It will inhibit phosphodiesterase. It could inhibit phospholipases. But please focus in on this particular one, the AC, as you have been doing, the adenylyl cyclase. I sent you a picture to state what happens when an opioid binds to a mu receptor, or an opioid receptor. So you should be able to have a 3 to 4 sentence answer, maybe 5, that details exactly what's happening when the opioid binds to the receptor, the alpha subunit dissociates, have an effect, and the beta gamma dissociate and have an effect. One of those effects would be to inhibit calcium channels. One of those effects would be to inhibit adenylyl cyclase. One of those effects would be to activate potassium channels, cause hyperpolarization. And yes, that potassium channel is labeled as an inward rectifier. Why do you think it got named that if it's causing hyperpolarization? Because it was discovered in mitochondria where the orientation is reversed. And so what happens to potassium with this channel in the mitochondria? It goes in the mitochondria. That's why it was labeled an inward rectifying channel. All you need to know is that that's a one-way channel. Potassium, when it's on the cell membrane and not the mitochondria, the potassium goes from the cytosol to the extracellular fluid, resulting in hyperpolarization. Okay. Pretty solid on opioids. And I think you guys nailed this pretty good in biochem, didn't you? No? Yes? Maybe. Now for the presynaptic and postsynaptic effects. I've tried to simplify a diagram that you have in your slides. You've got opioid receptors in the periphery, and you've got them presynaptic and postsynaptically in the central nervous system. I also added alpha 2 here, because alpha 2 is what type of a protein? It's a GI protein. So when I ask you, how does norepinephrine mimic the effects of opioid in the dorsal horn, you can say that its receptor alpha 2 has the same effect as the mu receptor. So Todd, what is this saying about mu receptors presynaptically? What does this picture tell you? So I'm going to have a positive effect on potassium channels and a negative effect on calcium channels. So presynaptically, what is that opioid receptor doing, usually? Hyperpolarization and decreased calcium influx, resulting in more or less vesicular release. Less. Okay. Jesse, postsynaptically, what would you tell me that mu receptors are doing, or opioid receptors?
Hyperpolarizing drugs.
Why do I care?
Because you're inhibiting the self-firing.
Where does that all summate? So you're creating an IPSP to counter any EPSPs from chemical messengers, and you are inhibiting nervous transmission. Right? Don't forget to try to get your vocabulary to intertwine. You know, use different words to say the same things, because you never know how I might ask something. Now, if I am activating this potassium channel, what part of the G protein, Major Fraley, am I using?
That is the beta gamma.
Yeah, the beta gamma dissociation. So, Tristan, if I am inhibiting adenylyl cyclase, what form of the G protein am I using? The alpha, right? Not the beta gamma, but the alpha. Track it?
Okay. Is that true of all GIs? Because we had it on muscarinic 2 and 4 as well.
Mm-hmm. Yeah, GI is GI. So a GI is always going to have this type of activity, and if it's got an alpha I subunit, this type of activity. Now, that's a lot of different activities it could have, but we don't have time to go into all of them, but you're absolutely correct. Opioids, where do they come from? Plants. Right? They come from the street corners. Yes, sir. All right, so you can get about 10% of opioid. So if you can take if you extract opium, you can get about 10% morphine from that opium. I don't care that you know everything that's in opium. Now there are three main types of opiates that come from opium. That's codeine, morphine, and thebaine. You probably have never heard of thebaine. I heard of it sitting in your seats, and then that was it. Never heard of it again. But I do know codeine, and I'm sure you've used plenty of codeine, and I do know morphine. Now, there is a substance that's used clinically for heart surgery, and it's called papaverine. Anybody heard of it? What is it used for?
We maintain the integrity of the vessel that we pull out the leg.
Okay, it's a vasodilator. It is a potent vasodilator. Now here's a chart that gives you a whole slew of agonists, a whole slew of partial agonists, antagonists, and some antagonists. Do I want you to know all of them?
Yes.
No. The ones I would like you to focus on are listed in the one chart, the gray chart back here, right? The fentanyl, anyway, you know which one I'm talking about. The fentanyl, the sufentanil, the morphine, the butorphanol, the meperidine, the buprenorphine. I'll never say that one. Sorry for the typo up top. But when you are using your opioids, how often do you guys think about the therapeutic index that you're delivering? Hopefully after this course, it's all the time. You guys use
I'm never sure.
I just want you to know, if you're comparing opioids to something like inhalational agents, opioids are much safer when given in isolation. When you're comparing opiates to induction drugs, the general point there is opioids are much safer given in isolation. Why do I keep saying given in isolation? Because once you mix in a benzodiazepine or something else, a GABAergic agent, all bets are off. Now, as usual, we have to go over some pharmacokinetic principles, and I've highlighted the ones of importance to you. And I don't necessarily care that you know the number, but I would like you to know which has a greater pKa, a less pKa. Right? How does protein binding rank? What about lipid solubility? And what about half-time? Richard, why do you think I highlighted those things?
Because those are how we're going to determine which drug we're going to give.
Right. So pKa is going to determine onset, right? Protein binding determines duration. And what about lipid solubility?
Onset.
Potency. Right? And then why do I care about elimination half-time?
Is that someone you have to deal with it?
That's right. And how many half times until the drug's gone?
4 to 5.
4 to 5. The next question that comes into effect is this thing, or the next concept is this thing called context-sensitive half-time. You were introduced to it in the volatile anesthetic lecture, and it was called decay times for those drugs. But if you look at the x-axis, if I take Michael and I put him on a Sufenta drip for 500 minutes, okay, or let's say let's go all the way to the end, 600 minutes, how long until 50% of the Sufenta leaves his plasma? About 40 minutes. But if I take fentanyl and I just run it for 2 hours, how long until that fentanyl leaves, 50% of it leaves the system? It's going to be a few hours, several hours. We're going to go back to the pharmacokinetic properties for a minute. I'm going to test you on the ranking order of each one of these in isolation. But the context-sensitive half-time takes all of these properties together. Because if you were just to look at lipid solubility, and you compared Sufenta to fentanyl, and then you also looked at protein binding, you would think that sufentanil should last a good long time. But it doesn't. And then we look at the elimination half-time of each. There's something about sufentanil the property of the drug that causes it to be excreted from the body at a faster rate. The point of this is, although I am asking you to understand the relativities of PK, protein binding, and partition coefficients, as well as the elimination half-times, when you look at this context-sensitive half-time curve, if you let it, it will confuse you. This is a conglomeration of what happens in reality if you run the infusion for a period of time. Why do you think remifentanil comes off so quickly? It has ester metabolism, and that's a huge machinery. So you can run that for as long as you want to, and 10 minutes later, 50% of it's going to be gone. But those other drugs don't have that type of metabolic machinery, so they depend on things like blood flow, redistribution. Katie brought up something important. People, how many people have been concerned with keep giving doses of Demerol over time? Because it has a seizure-like property. The reason it has a seizure-like property is its metabolite, normeperidine. So hopefully you understand that red is what you need to focus on. All right, so I've highlighted 6 of these drugs. And so I would like you to know the metabolic or the metabolite activity of those 6 drugs. Go ahead.
I see 5, sir. Is there another one?
Or 5 drugs, I'm sorry. I can't count. So codeine, what does it get metabolized to? Morphine. And if you're a fast acylator, are you going to have more or less morphine available than a slow acylator? You're going to have more. So if I give a fast acylator a dose of morphine or a codeine, and I give a slow acylator a dose of codeine, who would you suspect would probably have respiratory depression earlier? The high acylator, because you're going to have a greater proportion of the codeine turn into morphine. If I inhibit the CYP system, will I see the effect I want from codeine? No, because I'm counting on some of that conversion to morphine to get the effect that I want. Fentanyl. Fentanyl has a metabolite called norfentanyl. And not as great as the parent, it does have some opioid activity. Hydromorphone, Dilaudid. This is one time where you will have to discuss Dilaudid. Because it has a metabolite like Demerol that will cause allodynia, will increase the seizure threshold, may make the patient irritable. Okay. So that's H3G, hydromorphone 3-glucuronide. We discussed Demerol, or meperidine, has a metabolite called normeperidine. It has some analgesic potency, but it also could cause tremors, irritability, increased seizure activity. And just as an aside, why don't you see meiosis with meperidine? You see it with fentanyl, you see it with morphine, sufentanil, all your opioids. You're going to get pupillary constriction, but not meperidine. What does its structure look like, would you think? Remember, the Germans made this drug. The Nazis did, in an attempt to find an antidote for cholinesterase inhibitor poisoning. So if they're looking for an antidote, what works when you get nerve gas? What do you give yourself? Antimuscarinic, atropine. So Demerol has a structure that looks like atropine, and it blocks muscarinic receptors. So that is why you don't see pupillary constriction. 1939, created by the Nazis, called pethidine. Stars by things, important. Probably see it again. I mean, if it's in red, you better know this, but if it's starred in red, that's almost a guarantee. If it's in red, there's a high probability. But if it's starred in red, man, that's a guarantee you're going to see that again. What about morphine? Well, we know that it's a metabolite of codeine, but we also know that we can give it by itself. And it has two metabolites that you need to worry about, especially if you have a patient in renal failure. Okay, so morphine's broken down, it's glucuronidated. So let's do a quick review of what happens. You take a lipophilic drug, you run it through the liver, it gets either phase 1, phase 2 metabolism, it acquires a charge, and then what can you do with it? So you can excrete it through the kidney. Okay, so with that taken into account, imagine a renal failure patient. Now let me discuss this briefly while you're thinking about that renal failure patient. You give morphine. It's going to have these two metabolites, morphine 6 glucuronide and morphine 3 glucuronide. About 85% of it will be 3, and about 15% of it will be 6. 6 is okay. It's got about half the analgesic potency as morphine. But 3 is like H3G, is like more normal parity. It can cause allodynia. It can cause excitability, increased seizure threshold potential. And so knowing that, I give a renal failure patient some morphine. It's going to last shorter or longer than somebody who is not in renal failure, right? Because you can't clear the drug nor its metabolite. And you also put them at risk for respiratory depression, seizure, allodynia. Who here has heard of morphine-induced hyperalgesia? Anyone? So if you come across that, you have to consider the M3G metabolite. Because if it's excitable in neurons and increases seizure threshold, it should make sense on why you could create a sense of hyperalgesia or allodynia. Katie, has this pretty much followed Stolting? No, okay. This is word for word, cut and paste.
Word for word, yes.
Take a break. Come back in 10 minutes.
So now it's not sweet. I'll reference right now.
We're just whatever Stolting says. I mean, we'll discuss potencies. That's it. I mean, they all do the same thing. The context sense of halftime graph, though. We can't forget that. I haven't. You're on the G drive.
So, yeah, I went on that. Right.
My job was still.
Yes, that's my problem. Ready for this.
Let's do some more push-ups.
Yeah.
Sherry Profession.
That's great.
Saw that. That's probably good. See, that's on back.
Oh, yeah.
Literally every time I've ever been, it's the biggest neck I've ever seen on a woman. Thank you. Thank you for that. Every time. Every person that's ever taken
it takes you through. It's like consider using these drugs for these reasons. And it's like right on to how you not specifically. I haven't looked to see if there's like a comorbidity section. I think that's like my patient, our patient has no renal problems, so everybody's patient's different. And we still have to interpret the ABG and whatnot. Oh, awesome.
I didn't really look at anything at all.
At least you can kind of read the questions and say, oh, he's not awarded or
Yeah, I did too. The two things actually, this right there, a lot of double negatives. So it was like, which one is not one of these? Not this. And it's like, oh wait, I just see the second class. Yeah, so
like the exercises.
yeah, that always check. But if you know like what you're doing, then it's gonna be alright. Yeah. I listened to your first segment where we were talking about pain, and I got all the pain ones right. I haven't listened to any of the other ones. So
It's all right.
well, it's like, so you listen to an hour-long lecture, it takes you about 2.5 hours. I'm like, yeah, but I gotta stop and write it down and play it again.
Basically, every hour lecture, you need 2 hours of lesson. Sometimes you might have to hit your bed, sometimes you have to get
I have to put you on double speed to go through every time.
You give me about 2.5 seconds. Trying to talk louder. I can't.
Major Fraley really well.
Oh, no. I could never hear Katie's questions.
Oh yeah.
I always do this. I go, she's asking about. Oh, Katie's talking.
Wait a minute. I just
Start holding it up like this. Yeah.
How many drugs do we use? How many drugs do we use? These are
These are what they're posted.
I got a lot of
So those are just extra questions on top of that.
Just think of the people's questions.
Yeah, I was about to say it's messed up. Yeah. I found that recently that my grandma's side was Austrian. She was Jewish, and she married an Irish guy, and they're stuff, but they were all Austrian Jews. Yeah, so even if we trace it back, it's kind of Did you hear that they were, what is it, the Ebola outbreak over in West Africa? It's completely out of control. They can't contain it whatsoever. They've got like a security corridor that's locked in. They're not really treating it. They're just keeping all the dead people. Too many people. Too late.
This material's on my page block.
So the test is not next week, it's the Thursday after. Friday after. Is it Friday after? Oh, sure. Friday. Not next Friday, but Friday.
Nope. So I'll be here Saturday, and I'll be here the Sunday following. Not this Sunday, but next Sunday. So.
Would you mind asking questions in your style? During that, would you mind just asking particular questions in your particular style?
Yes.
Asking questions. It takes a while to get used to that.
Yeah, but let's give you purple paint and say, blue. Okay, here we go. So, does anything on this slide here surprise you? Morphine side effects. Getting warm when they get it, itching, euphoria, they get a little sedated. So the euphoria is view related, It also has some kappa activity. Sedation is related to the kappa receptor. Why do you think that they feel warm? It releases histamine, vasodilation, increased peripheral temperature. Same with the itching. What does histamine do to nerve endings? Sensitizes them. That's why if you get tingly or itchy, that's why. Something's happened to your nociceptors that have sensitized them, and now you're feeling the effects of that sensitization. So morphine, if given enough, can you do surgery? If you give enough of it, sure. Will you get anesthesia? No. You'll get a very high degree of analgesia that might get you through the procedure. But the point is that these are opioids, and they do have a certain threshold. Now, if you have this dull pain, morphine's going to work well. Opioids are going to work well. But if somebody is dissecting you and feeling into your intestines and your visceral organs, morphine may not be as effective as something like an anesthetic. That should be of no surprise to you. Tristan, what technique is this slide describing? You may have heard of it before. If I give it before something, what am I doing? You're giving it preemptively. So what it's saying with this slide is that if you administer the opioid prior to the event, that you will get better relief for trying to rescue the patient after the event with the opioid.
It's a concept not well understood by physicians.
Now, Michael, if you don't have pain and I give you morphine, what happens?
Feel bad.
You feel better. You get euphoric. But Lance, if you're in pain, are you going to feel the euphoria he feels? No, it's going to just handle the pain. So if you're not in pain and you take an opioid, you might get a little euphoric, you might get a little obtunded mentally. But if you're in pain, it's going to treat the pain, and more than likely, you will not experience any of that change in medication. Dysphoria is the opposite of euphoria. So I could give it to Michael, and he could do two things. He could either freak out or feel better. Usually you feel better versus freaking out. Right, you can get euphoric or dysphoric in the absence of pain. But if you have pain, the opioid is going to cover the pain. And usually that's it. So you give a lot of morphine quickly. Sorry, I'm pushing a little bit today. Now, what's the pKa of morphine?
7.9.
7.9, so you give it, and it's going to be relatively charged, right? Is it very lipophilic? No. Is it very highly protein bound? No. So, you give this drug, and it takes a while for the effect, yet you have a high plasma concentration. Why? Does it pass through membranes very well? No. Stays in the vascular system. It takes a while to penetrate the blood-brain barrier. Right? So you have to think, why do I have a high plasma concentration, but no effect yet? What's that? Exactly. It doesn't penetrate. In fact, if you look at its partition coefficient, it's 1.
It is what everything else is compared to. Is it lipid soluble? Yes. But it's the lowest, has the lowest lipid solubility properties of the opioids. It's what everything else is compared to. But the point here is you give a huge bolus. Are you going to see your onset very quickly? You give morphine, how long does it take to set up? 15 minutes, 20 minutes, 30 minutes sometimes on the patient. Right? Now the opposite is true too. It will get trapped in lipids. Right? And so as it's wearing off, and what else once it gets trapped in lipids, what else does it do that I should point out? Why does it have an increased duration of action? It has a metabolite called M6G. And so the actual morphine concentration in the blood drops, but what goes up in the blood? M6G, which has 50% of the analgesic efficacy of morphine. So that is what he's trying to say when you read this. You have a high plasma concentration, but you have a slow onset. You're going to have a low concentration, but a continuation of the effect. That is what he's trying to say. Now, not much is going to get into the brain, but what gets in there is effective. Now, I would understand why morphine has a difficult time penetrating into the brain. There's 4 reasons. This sets up for one of those, which of the following is not true, as to why morphine has difficulty penetrating the CNS. It's not very lipid soluble. It is a weak base put into a more acidic environment, so it picks up hydrogen ions. Its protein binding, it has about 35%. And then it gets chewed up pretty quickly by the liver. Then, why does hyperventilation make that statement true up top? So, I increase your body's pH. Why do I increase the uncharged form of morphine?
If you're increasing the pH in the blood, then the PK regional is already saying pH match that.
What are you taking out of the blood? Hydrogen ions.
Can you repeat that, sir, please?
So, sure. So if I alkalize, if I take the blood pH from 7.4 to 7.6 by hyperventilating, what have I done to hydrogen ions in your blood? I've buffered them out, right? So I have less hydrogen ions available when I inject morphine. So am I going to have more morphine or less morphine that's bound to hydrogen? Less. Because you have less hydrogen. So that is what this statement is saying. Okay, can you explain to the class the bottom part of this statement?
Bottom statement, so from my understanding, your respiratory acidosis means you're hypercapnic.
Okay, so if you get hypercapnia, you can increase your blood hydrogen ions, okay?
Yes, and then thinking about your CO2, your partial pressure, carbon dioxide's going to be high.
CO2 goes up, got it?
So, and CO2 is a vasodilator in the brain.
CO2 will cause vasodilation in the brain, absolutely.
So even though you're in a acidotic state, then you have a pKa of 9 or 7.9.
Okay.
Then you would have more things in the charged form, but what you don't have in the charged form, it's still going to get to the brain easier because you're vasodilating in the brain. So you have an increased effect in respiratory acidosis. The pKa is.
Got it. So this is where reading Morgan and McHale will confuse you if you haven't read Stolting. So Morgan McHale says that acidosis is going to increase the non-ionized portion that's delivered to the brain. Ultimately, that is true, but they don't tell you why. Because that statement by itself, I would say, is wrong. But then you go and read Stolting. Stolting explains what's going on. If I get acidotic, I have more hydrogen ions, and those hydrogen ions are going to cause me to vasodilate. I'm also going to bind up more morphine. But look, think about this in your mind. Without the acidosis at normal pH, let's just take a number. Let's say we delivered 100 molecules of morphine to the brain. Okay, got it. That's in normal conditions. And if I have 30% that's ionized or unionized, then that 30% gets delivered. I just want you to think about that concept. That's quite different than if I deliver 1,000 molecules to the brain because of an increased blood flow. Now, even though I have a higher proportion charged, ultimately I have a greater amount that's also uncharged compared to the 100 molecules. Try to envision that. That's what Stolting's saying. You deliver a greater amount of drug. And because you deliver a greater amount during acidosis, even though you're acidotic, you're going to deliver more to the brain. And ultimately, because of mass action, what is always happening to that weak base? It's always binding, unbinding, binding, unbinding, binding, unbinding, regardless of the pH. So if I can deliver enough to the area, I'm going to have onset of action. Does that sound like something we've talked about before? That sounds like chloroprocaine, doesn't it? Same concept. If you deliver enough of the drug, you're going to push free fraction into the brain. And then the point that he makes, after all of that, the point is that blood flow may be more important to the onset of activity than pH. Now we talked about the metabolism of morphine, and you're going to be required to understand what M6G is and what M3G is. And you also have to understand that codeine can be formed from morphine, because that's not a one-way reaction. And in the gut, check this out. The metabolites, M3G and M6G, if they find their way to the GI tract, guess what they become converted to? Morphine. So there's a reason that there's such a long duration of action with morphine. It has mechanisms that give you a metabolite that has an effect, and there are some mechanisms within the body that can cause its metabolite to reform into the parent compound. We've nailed this to death. So what does M3G do? Seizures. What does M6G do?
Half the time.
It's got half of the analgesic potency, which is made by a greater capacity, 3 or 6. 3. Yeah. In the elderly, what do you know to be true?
Overdoses.
They're sensitive. What about their liver? Does it work as well as yours?
No.
So can they conjugate this morphine or glucuronidate this morphine as readily? So you inject it, and over time, their plasma concentrations are higher because they don't have the mechanisms in place to break this morphine down. But if I give it to Kenneth here, I inject it, and what does his body immediately start doing? Glucuronidating it, turning it into M3G, M6G. We talked about the renal dysfunction example. I would not discount that because I'm sure you're going to see that again. One thing you may not know is that morphine has a better effect in women compared to men. And there seems to be gender differences in regards to kappa and delta receptors. How do I want to say this? Women experience more pain, but can tolerate it better. That's what the literature says. All right, let's talk about what morphine does to the cardiovascular system. A lot about morphine here. It's your prototypical opioid. By itself, the statement was made in 1969 that morphine is the most cardiovascular substance known to man, most cardiovascular stable substance known to man. You can give an outrageous quantity of this, and blood pressure will be maintained, heart rate will be maintained. But what's the caveat?
Stop breathing.
Well, but it's given by itself. Because if you start mixing drugs with this, you don't get the pure effect of the opioid. Now you're starting to see synergy, right? Instead of 1 + 1 = 2, now it equals 12. Now, if they're laying supine, so I put Cod in bed, I pump him up with morphine. I just hose him with it. Give him 100 milligrams. And then I ask him to stand up. He's going to pass out because I have blunted his sympathetic mechanisms to respond to the change in pressures. Right? He's going to have decreased venous filling, which should initiate some type of barrel response. But I gave him so much morphine that now he has orthostatic hypotension and he passes out. That is what that statement is telling you right there. Any ER people here? What was part of your MI protocol? Morphine. Morphine. Why? It is. It increases venous capacity.
But that's only left-sided.
Yes.
And there's too many histamines.
No, you can't. Okay, whatever. Oh, yeah, just stick with Stoltine, all right? They got other stuff, I get it, right? But if I asked you on a test, why was it given in that condition? Because it increases venous cooling. It decreases preload. That's what he says. Okay. Now, here is the answer to the why does the CO2 curve shift to the right? You give morphine or any other opioid. I'm sorry, not yet. The next one. This is going to be for bradycardia. What two centers do you have in your midbrain?
Cardio accelerators.
Cardiovascular center and your respiratory center. We're going to focus on the cardiovascular center right here. So you give morphine. Why does your heart rate slow down? What kind of innervation do you have to your heart?
Predominant parasympathetic.
Dominant parasympathetic, and you have some sympathetic cardioaccelerator fibers. When you give an opioid, what do you preferentially decrease? Sympathetic activity through a GI mechanism. So now your vagal influence can dominate, and in part, that you increase your vagal influence to your heart rate, and what's going to happen? It's going to decrease through acetylcholine mechanisms, as well as that there's opioid receptors in the heart that will augment that effect. If I am in the SA node, the AV node, I take that back. If I'm in the AV node, what happens there? You get a little bit of a delay, right? SA node impulse comes in, and you get this little bit of delay before you hit the Purkinje's. Now, on morphine, what happens to my QT interval? It prolongs. Do you think there's more? Do you think there's opioid receptors on that AV node? Yes. And if you activate the GI receptors in the AV node, do you increase or decrease resistance? You increase resistance and you have a longer delay.
Are you talking about PR interval or QT interval? QT is repolarization.
Oh, you're right. I'm talking PR interval.
Okay.
Yeah, PR interval. I'm sorry. I'm talking from the point where the P wave ends to the initiation of the QRS. Yes, so the PR interval. Thank you. It's nice to have an NP in the classroom. All right, so, and it appears that the more lipophilic you are, the greater your effect on the heart rate. So, if I gave remifentanil or I gave morphine, based on what I just said, the heart rate should drop more in which patient? The one receiving remifentanil. If I use sufenta versus fentanyl, sufentanil, because it's more lipophilic. It appears that the penetration, the lipophilicity, is directly related to the slowing of the heart rate. Histamine release. We all here have seen it, I hope. You give 10 milligrams of morphine in about 3 seconds. Patient's arm turns red. In some patients, not everybody, some patients' arms will start turning red. Their chest will get red. They may complain that their chest is getting tight. Are they having an anaphylactic reaction? Maybe. But that's a zebra. Right? The horse would be they're having an anaphylactoid reaction. They're having an anaphylactoid reaction. And how would you differentiate it from the zebra? The length of the event. Right? If it's anaphylactoid, is it going to prolong? No. It's only because you've dumped a little bit of, and does histamine have a long half-life? No. Right? You'll see an effect, and it will go away. Now, can you decrease the symptoms of an anaphylactoid reaction?
Sure.
What do? You give them an H1 and H2 blocker prior to giving the Benadryl or the morphine. Okay. Now, this slide in Stolpine, or this picture in Stolpine, shows you the difference in giving a phenylpiperidine like fentanyl versus an opium derivative like morphine. So you have all these patients which you injected morphine, and you get a plasma concentration. You have all these patients that you've injected fentanyl, and you see a histamine plasma concentration. So Robert, what is that picture telling you? Fentanyl has less histamine release, if hardly any at all. Now, how do you stop or prevent? We talked about the H1, H2 blockers, but what else could you do with the morphine?
Get it slow.
Slow down in your administration. Exactly. So this slide again is showing you that sufentanil and fentanyl do not release histamine, but morphine does. I think Stolpine spends a whole page on that. Many of you will be introduced to nitrous oxide. I am a fan of nitrous oxide. I use it all the time. What this slide is saying is that if you use nitric oxide with morphine by itself, or you use nitric oxide with fentanyl by itself, you shouldn't see any cardiovascular compromise. I'm sorry. Yeah, when I said alone, yeah. Oh. when you use morphine alone, or fentanyl by itself, and nitric oxide, I'm talking about the bottom first, and then I'll talk about the top. Nitrous oxide, sorry. No. Self-conscious. So if you use fentanyl by itself or morphine by itself and nitrous, you're good. If you start mixing them and use nitrous, you may see some drops in your hemodynamic parameters. That is what this slide is saying. And I've seen it. You know, you use morphine and fentanyl together and you start the nitrous. I've seen some substantial drops in blood pressure. And I don't use morphine anymore. I use Dilaudid, so I don't see that. Freddie, why do I care about opioids and benzodiazepines? Right, so by themselves, given by themselves, morphine is pretty safe, right? Just got to worry about a little bit of respiratory depression. Versed, given by itself, pretty safe drug. But as soon as you start mixing opioids and benzodiazepines, there are no standards. What that means is I can't tell you what patients will respond well or not well to that mix. All right, here is the respiratory question that I sent out. Why do opioids increase the CO2 response curve? So you have to build up your CO2, which is then converted via carbonic anhydrase into bicarbon hydrogen. Hydrogen will activate chemoreceptors and create an excitatory postsynaptic potential, which will cause your respiratory center to send messages through your phrenic nerve and your diaphragm fibers. You breathe. Well, now, if you give an opioid, especially mu receptor agonist, do you create UPSPs or IPSPs? IPSPs. So now you need to have more CO2 to generate more hydrogen ion to facilitate the formation of more EPSPs. So what happens? You give the fentanyl, the sufentanil, the morphine, the Dilaudid, whatever you want to use. What does your patient do? Am I wrong? And what's happening? So the CO2 is building up, gets to 50, triggers enough hydrogen, or forms enough hydrogen ions. You fire enough EPSPs. You take this big, huge breath, right? But when you take that big, huge breath, you remove some of that CO2 from your bloodstream. So now you got to wait for it to build up, and then you got to make more hydrogen ions, and then more EPSPs, and then you take another big breath. But now that you've taken that big breath, more CO2 has left your system, and now you got to build up. So you see how you get those less frequent but greater tidal volume breaths? So you're creating all these EPSPs. So when your CO2 gets to a certain point, now you have triggered a huge stimulus that is going to recruit more motor units than you normally would have in your normal tidal volumes.
But it didn't fire off earlier.
Because you've got the morphine on board or the fentanyl on board creating the IPSPs.
To get more IPS. So then as soon as you get enough action or something produced.
But it's a greater response. Right. And that is what this slide is saying. Believe it or not. So now you know. So now think about this. You want to give your Narcan, and you've been taught to give it at 0.4 milligrams as a single dose. And I tell you that if you ever do that in my OR, I will kick you out of my OR, and I won't work with you again for a week. Why?
Never works.
Not only that, you got a patient in surgery, and you have just removed all of their analgesia. They're going to be in extreme agony. What happens to their sympathetic nervous system? It's an overdrive. And what does that cause the patient to run the risk of? Neurogenic pulmonary edema. If you have an acute increase in your sympathetic nervous system and you release a huge amount of norepinephrine from the nerve endings surrounding the bronchial smooth muscle and the vascular and the pulmonary vessels, you run the risk of putting them into fulminant pulmonary edema because you have vasoconstricted so much, increased that hydrostatic pressure so much that you move that fluid out of the pulmonary vasculature and into the space, the interstitial space, or even the alveolus. So how am I going to have you titrate your Narcan if you use it? You're going to get a 10 cc syringe. You're going to fill it with 9 cc's of sterile water, normal saline, whatever you want to use as your diluent. Then you'll add that 0.4. What does that now make the concentration per ml? 40 mics. And I will have you give it 1 cc, wait 5 minutes, give another cc. And by doing that, you are removing some of the opioid or displacing some of the opioid that's modulating your ventilation, stopping your respiratory drive, and not totally taking away a patient's analgesia. You see that? But what's the risk you run? Hypoxia, ultimately, but why? Because you just restored their ventilation. But now you're going to send them to the PACU. How much opioid did you give? What's the half-life of the opioid? And what's your half-life of your Narcan? Right? So try not to use it so much. So now you understand this picture. And here's the point. If you've got a patient that has a lot of opioid on board, and that's really all they have on board, if you go up and tap them, take a breath. Okay. They'll take a breath. They'll do it voluntarily. Right? Now, I don't have any Versed on board. I don't have any propofol on board. I just gave Freddie a bunch of Dilaudid. And he had stopped breathing. Right? He's waiting for his CO2 to build up. So if I come over to Freddie, he'll take a breath. Any questions on that? Anything that I've said that is contrary to what you've seen in practice? Okay. Now, what's the biggest dose of fentanyl you've given? At one time. You're not going to be surprised to use 500 in one shot. You're not going to be surprised in some patients where you use 30 milligrams of morphine or 6 of Dilaudid. Surgical pain is not post-op pain. So I'm not saying that for every patient. I'm heavy with my narcotics and I'm light on my gas. I like to use nitrous, but I also like to use a high amount of opioid. You give an opioid, and we just said that you preferentially inhibit sympathetic activity. So James, describe what would happen to airway resistance then.
For inhibiting sympathetic activity.
Yes.
So sympathetic activity is going to cause bronchodilation.
Yep.
So inhibiting that is going to be constriction.
Why is it constriction? You're right. So sympathetic activity goes down, parasympathetic activity increases. What on the smooth muscle of the lung will cause bronchoconstriction?
E3.
muscarinic 3, right? But on that note, let's think about this. Okay, so muscarinic 3 is a GQ protein. There are opioid receptors on bronchial smooth muscle. The key being smooth muscle. Now, if I activate the GI protein on smooth muscle, do I dilate or constrict? If you know GS dilates smooth muscle, then GI has to constrict it, right? And it's because you are inhibiting adenylyl cyclase, you're inhibiting the formation of cyclic AMP, you're inhibiting the activity of protein kinase A, and you're inhibiting that early phosphorylation of myosin light chain kinase. And so now that myosin light chain kinase can bind to the calcium calmodulin and then become phosphorylated and then cause your smooth muscle contraction. Right? So there's two mechanisms that may increase airway resistance when given through opioids. And I didn't even talk about if it has a histamine release or not. Yeah?
So are you for M3 and M2?
Mu receptors and M3. Yep. Opioid receptors, mu receptors, and M3. So the reason you cough, it's a reflexive action, and what is it trying to do?
Clear your airway.
It's trying to clear your airway. Okay? Reflexive. It is a primitive reflex. It is centered in the midbrain, in the medulla, and you have opioid receptors on them. And so it makes sense that if you can stimulate a opioid receptor, stimulate a inhibitory process, that you would get depression of that reflex, and you would cough less. I'm not worried that you're worried about dextromethorphan. That is a opioid isomer, and it actually binds to the NMDA receptor. I don't care that you know. If I could magically maintain normal capnia after I give an opioid, and you do it all the time, what is that called? Mechanical ventilation, controlling the minute ventilation, and you give an opioid. What this is saying is that in the absence of any changes in your CO2, I'm going to give an opioid and I'm going to decrease cerebral blood flow and possibly decrease ICP, although there's no real good evidence. There's a suggestion, but no real good evidence. But think about this. What do you look at? Let's take this head injured patient, since we're talking about ICP. We'll just assume that Stolten's talking about head injury. Why do I like the pupil? You can assess reflex action. But if you give an opioid, what happens? You obliterate that positive light response, right? As well, if you give an opioid, enough of it, do you sedate the patient? So there's this fine line. Opioids may be good in head patients, but if you want to assess them, it's going to inhibit some of your signs that you're looking for. As well, if you give an opioid and you are not mechanically ventilating this patient, Katie, what happens? You give someone an opioid. What happens to your CO2? And they're not being mechanically ventilated. And what happens to blood flow, cerebral blood flow? And if cerebral blood flow increases, what happens? ICP goes up. So that is what Stolten is saying with this particular area of instruction. One of the things that phase 2 is going to hammer into you, because it's the only thing they know about opioids, is fentanyl causes truncal rigidity. You give enough fentanyl, it's going to be hard to ventilate because of that truncal rigidity. Why does it cause truncal rigidity? And is it even true? So there is evidence that shows that if you give, especially the lipophilic opioids, Sufenta, fentanyl, and you give a large dose, that it might be hard to ventilate. And it could be that there is a constriction of the smooth muscle, the bronchial smooth muscle, but it might be something just as simple as a dopaminergic influence on your skeletal muscle of your vocal cords. Does dopamine go up or down when you give an opioid? Oh, it goes up. If it didn't, it wouldn't be so addictive, right? Why do people crave something? It's because dopamine, it's that rush. You give an opioid, dopamine in the brain, in the basal ganglia, in those reward centers, in that limbic system, it goes up. Now, knowing that dopamine is associated with rewards pathways, I also know that dopamine is associated with moving and skeletal muscle movement, right? Parkinson's. So if I increase my dopamine, I'm going to cause skeletal muscle to become rigid. One of those skeletal muscles controls your vocal cords. And so it could not even be anything related to skeletal muscle rigidity around the thorax. It might be related to laryngeal aperture opening. Right? If you make that smaller, it's harder to ventilate. I'm going to ask that you know both. Right? The truncal rigidity, it might be a skeletal muscle influence on the intercostal muscles. That doesn't really make sense because you still should be able to ventilate. It might be the simple fact that you gave the opioid, which decreased the sympathetic activity, increased parasympathetic activity, as well as possibly activated some opioid receptors on bronchial smooth muscle. Right? So with acetylcholine and with opioid receptors on bronchial smooth muscle, I should get increased airway resistance, right? So there's truncal rigidity. Now you can school your phase 2 on what the exact mechanism is. And you know what they'll do? They'll say, why does it occur? And then you say, I don't know. And then what do they say? Why don't you get back to me? Because in their mind they're like, I don't know either. Anytime you hear to look it up and get back to me, say, I don't know it myself. So for truncal rigidity, what are some of the things to key in on? It could be a dopamine influence on motor pathways, right? I could cause skeletal muscle constriction of the laryngeal muscles. I could close the vocal cords. It could be dopaminergic influence on the intercostals, increasing my tension along the rib cage. Or it could be as simple as I've decreased sympathetic activity quickly, and now I have an increased vagal influence, and I know that there's mu receptors on bronchial smooth muscle, so those together could cause a hypertonus of the smooth muscle. But if you're able to discuss those 3 things, you'll be fine on this portion of the exam. One thing to note, too, the more lipophilic the drug, the greater or less the incidence of truncal rigidity. The greater. Yes?
So you said smooth muscle, but it says skeletal muscle.
Right. Skeletal muscle is the dopaminergic influence on skeletal muscle. Smooth muscle is separate, right? So we said earlier that airway resistance might go up simply because we've given an opioid and decreased our sympathetic activity. Well, I know that the vagus innervates the bronchial smooth muscle, and I know through a M3-GQ protein that it's going to get tight, right? I also know that when I stimulate any mu receptor that's on bronchial smooth muscle. It's a GI protein that's going to constrict. Guys, that skeletal muscle problem, if anything, it's related to the release of dopamine around the basal ganglia and the striatum, which in turn will cause your muscles to tense up. Now, why do you get meiosis? Why do you get meiosis? I give you an opioid and your pupils constrict. The bottom line is that you've increased acetylcholine outflow to the ciliary muscles up here in blue, and then, like a laundry bag, that muscle tightens up and the diameter of the pupil gets smaller. But how does that happen? Well, it appears there's this thing called the Edinger-Westphal nucleus, right? And you have this inner neuron that's within this structure, a GABA interneuron, that is tonically inhibiting the acetylcholine influence of that nucleus. This is very familiar to something you learned in regards to the descending pain pathway. Same concept. So if I am able to stimulate a mu receptor within this nucleus, then I can remove an inhibitory process in this nucleus, and I increase my parasympathetic outflow to the iris. That's it in a nutshell. You give an opioid, you remove GABA inhibition, and now you increase parasympathetic activity from that nucleus all the way to the radial muscle in the iris. This is another side effect that you really don't become tolerant to. Yes?
Is meiosis a result of psoriasis, though? Because there's like the muscle of the people, and then there's just ciliary muscle inside the eye, which is a different thing from the lens, right?
Ciliary muscle.
I'm just trying to think of the combination there.
That blue up there is the ciliary muscle. That's the drawstring. I pull it tight, and it closes. The ciliary muscle in the eye is, it has the band of muscle that when it gets tight, it closes. And when it relaxes, it opens up. When it gets tight, it closes. When it relaxes, it opens up. What are you thinking about?
I thought the ciliary muscle was on, but there's three, you know what, I'm just going to stop.
End result, you pull muscles tight that are the colored muscle in your eye. There's a little band on the inside. When that gets tight, your pupil closes. That's what's happening here. All right, that's it. See you later.
Dr. Ben, are we still re-insulting?
I mean, this is cut and paste from Stolte. If you have questions, yeah. But as always, I'll give my spin on it when it comes to test questions. Yes?
So what you're saying, sir, is opioids are stimulating or putting